A very, very good evening to everyone, and welcome to the program called No Thrombosis. So, No Thrombosis program is actually dedicated to completely all the cardiologists. Specifically, this program we discuss all in clinical cases, the real life challenging cases, specifically thromboembolic complications cases, patients related with CAD, PAD, DVT, pulmonary embolism. So from behalf of MPure, we are very glad to inform you that we have won ninth edition of SIMS Healthcare Excellence Award for most engaging scientific platform from any pharma company, right? So that is one thing where No Thrombosis has reserved, because since last 2 years we are consistently doing these programs and consistently providing a lot of insights specifically on thrombosis to all our delegates. So today, the No Thrombosis program, our course director is none other than Dr. Praful Kerkar sir. Dr. Praful Kerkar sir is former president of CSI from Mumbai chapter. Sir, he has been a chairman of Board of Studies and Maharashtra University from Health Science. Sir has done presentation in national and international meetings, including the prestigious Orients and as well as awards. Several publications in national and international journals has been awarded to Dr. Praful Kerkar sir. So Praful Kerkar sir has done CSI guidance document on acute MI and HF care during COVID. Sir was chairman of the Pinnacle India Registry in collaborations with ACC. Notable trials, sir has participated in many trials as the principal investigator, published many articles. But the notable trials, you can see Paradigm, HF, the Paradise MI, and Odysseus and Outcomes, Select, Squad, Impact, etc., etc. So from behalf of MPure, I welcome to Dr. Praful Kerkar sir for today's program as a course director. Sir, welcome, sir.
Hello, Ravi. Yeah.
So our moderator is Dr. Gaurav Verma sir. Dr. Gaurav Verma sir, he is MD in gold medalist, as well as he is the DNB in medicine, and he is GM cardiology and associated fellowship in SCAI. Sir has a senior interventional cardiologist at SMBT hospitals and Nashik and Tambe Hospital, Sangamner, and also as a visiting faculty in visiting interventional cardiologist at many of the institute. As well as the sir has done a presentation in many national and international meetings, including prestigious orations and awards and several publications in national and international journals. Sir has consistently associated with the No Thrombosis program. So once again, from behalf of MPure, I welcome you, Gaurav sir, for our program, sir, for No Thrombosis. Welcome, sir. And our first speaker is Dr. Sunil Jatania. Dr. Sunil Jatania, he's completed DNB in medicine and DNB in cardiology, and he also completed PDCDM. Dr. Sunil Jatania is consultant interventional cardiologist. So presently working in Ajanta Heart Clinic and Diagnostic Center, Mumbai. He has an experience of 18 years in the field of cardiology and many articles published in national and international journals. So welcome Dr. Sunil Jatania sir for this today's program. So our next speaker is Dr. Ankit Dedia. Dr. Ankit Dedia is completed DNB medicine and DNB in cardiology. Dr. Ankit Dedia is consultant interventional cardiologist in Mumbai. Presently attached to Holy Family, Symbiosis, Messina, Biclo Hospitals, that is Hinduja Healthcare, Neuron and Global and Bhartiya and Aroganiti hospitals. So, and also Dr. Ankit sir has published more than 20 articles and participated as a faculty in many in Indian and national conferences. So welcome, sir. Welcome to Dr. Ankit Dedia sir to our No Thrombosis program. And our third speaker is Dr. Anirudh Vaishya. Anirudh completed MD DM in cardiology, and he has also done a fellowship in FACE. He is consultant in electrophysiology and pacing and interventional cardiology in Vishesh Jupiter Hospital, Indore. More than 10 years of clinical experience in interventional cardiology and electrophysiology. He is also awarded specifically in heart failure care, including EPS and RSA pacing, as well as ICD and CRT therapies in central India. So from behalf of MPure, I want to welcome to Dr. Anirudh Vaishya sir for today's program, No Thrombosis. So first, our case presenter will be Dr. Sunil Jatania sir, followed by Dr. Ankit Dedia and Dr. Anirudh Vaishya. So with this, I will request Dr. Praful Kerkar to take the session forward. So over to you, sir. Praful sir, Kerkar sir. Yes.
Well, good evening to all. Thank you, Ravi, for those kind introductions. We have an excellent faculty today a very young interventional cardiologist from Mumbai as well as from Gujarat. And then we have as moderator, my junior colleague from the KEM Hospital Department, Gaurav Verma. It's a pleasure to be with you all on this faculty. And as Ravi mentioned, this program has been going on for the last 2 years. Actually, it took the impetus during the COVID times. Thankfully, we are done with COVID today. COVID, as we know, was a thromboembolic problem that we had to deal with, and our experience in treating thromboembolic disorders throughout has helped us to even deal with the thromboembolic complications of COVID. Now, having said that, this program is very aptly called No Thrombosis. No, the capital NO in that is what we would ideally desire to have when we're dealing with the thromboembolic disorders, that we get rid of thrombosis as also we prevent thrombosis. But the knowledge, the no part of it, the knowledge of thrombosis, thromboembolic complications, and thrombocardiology as it is continuing to grow. It has grown in leaps and bounds since the last 50 years. I believe warfarin, the agent that we used to use and which we still use for prosthetic valve thrombosis, or for that matter, pure mitral stenosis, we still got to atrial fibrillation associated with pure mitral stenosis. We still got to use the good old warfarin, which was invented even before I was born, I guess, right? So, but then we have to evolve. And talking about evolution, it is a well-known fact today that DOACs or NOACs, whatever you would like to call them, predominantly the ones that are available is either a direct thrombin inhibitor, dabigatran, or factor Xa inhibitors, that is rivaroxaban and apixaban. And thankfully, all three today, including apixaban, have gone off patent. And as far as cost business is concerned, there is no real reason today, now that our own Indian companies are making all the three molecules, the DOACs or NOACs, we shouldn't be hesitant to choose DOACs or NOACs over the good old warfarin, except for the two indications that I mentioned in dealing with these thromboembolic disorders. And having said that, amongst them, now all the possible indications that we talk about, right from going up to the brain, the stroke prevention, or for that matter, treating acute ischemic strokes, to going down to the heart level, ACS and ACS-like conditions, or for that matter, even chronic coronary artery disease where thrombus is incriminated. And for that matter, in that sense, rivaroxaban is a little versatile agent molecule that can be used for chronic coronary artery disease also. And then we, of course, have the most dreaded pulmonary embolism and venous thromboembolism, DVTs. So venous as well as arterial thrombosis. Now, as I said, this field is continually evolving, and I might want to tell our delegates who are attending, as well as I'm sure the faculty is aware of it, and at the latest meeting, the ESC that took place about 2 months ago, end of August, that took place in Europe. At the ESC meeting, there was such an emphasis on a new version of these so-called, we may want to call them also NOACs or DOACs now, in the sense that they are factor 11A inhibitors, and that is very important because it preserves the ability of the patient to create a clot yet when there is bleeding. So it preserves that ability. So it uncouples hemostasis on the one side and yet is effective, and has been compared also. Certain of these factor 9, 10, 11A inhibitors have been compared with apixaban also, and have been proven to be, of course, phase 2 trials. But the field will continue to evolve, and so we will also evolve. But theory apart, this meeting is all about clinical cardiology, in the sense that clinical scenarios in all these thromboembolic conditions that we have talked about, and to deal with them, and what are the special challenges, when you balance the risk of bleeding on the one side and the risk of thromboembolism on the other side, So how do we go about doing it? And the first speaker, all of them I mentioned to you, the faculty are very erudite people, very well knowledgeable. They are young, dynamic interventional cardiologists. For that matter, I'm happy to know that we have an electrophysiologist with us also. So the first speaker is Dr. Sunil Jatania, who will discuss an atrial fibrillation patient, I believe, and what are the nuances of that particular case, and then we'll deliberate on it. Go ahead, Dr. Sunil Jatania. Yeah, could you go on a slideshow? We can see your slide very well.
Yes, sir. Yeah, audible and my slides are visible.
Yes.
Yeah.
Yes, very good. Go
Good
ahead.
evening, Kerkar sir. Good evening, my colleagues. Kerkar sir, just before I start my thing, I have fortunate been learning from you from many of the conferences and such presentations, and it's always been a great learning experience, sir. Whenever I am sharing any presentation in front of you, and the three presenters today, I had that opportunity to work with them. Myself, Ankit, and Dr. Vyas, we all were together at Holy Family, where I and Ankit were doing our cardiology, and Dr. Vyas was doing his fellowship under Dr. Yash Lokhandwala. So this
Okay.
presentation essentially is more like a family gathering rather than an actual presentation for three of us. To begin with, sir, I have kept my a simple case to discuss about the approach to AF rather than sharing some. We all have been seeing AFs every now and then, and I'm sure there is nothing much of new that needs to be shared. As sir said, few of the drugs are there since even sir was born, as he said, and hardly any new things have turned up, only a few changes in the approach. So I share the case, Mr. GR, 62-year-old gentleman who presented to our clinic with mild palpitations since past 2 weeks. He had some lightheadedness feel, but not really any fainting or such serious symptoms. And there were no chest pain or orthopnea or PND. There was a past history of smoking and hence some mild COPD component for which he was put by a chest physician on triotropium and SOS salbutamol. And he was known hypertensive and he was taking tablet telmisartan 40 milligram once a day. Personal history, as I discussed, he had smoking since it stopped, he says, since past 15 years, and occasionally he consumes alcohol. So in examination, really nothing much except for his heart beat and pulse that was around 110, irregular pulse. BP was fairly okay. There was no pedal edema, no JVP raised, no murmurs or anything on auscultation, no bruit. Peripherals were warm and all the peripheral pulses were well felt. Not really much in the lab workup. And the ECG just showed the AF classic rhythm with a heart rate of around 110, 120. So basically, sir, with the permission, would just like to discuss the approach of basic approach. I learned there are some general practitioners, some physicians, and especially, as you pointed, most were the budding doctors or the new people who have come on board. So we'll be sharing some basic approach to AF and then we can discuss it further, sir. So usually this is a old pattern, but I liked it and hence I'm putting it here because the approach is explained step by step. So very easy to approach. Like, first we decide whether, which type of AF is there. And we know different types of AF. The further jargon of English has been added to these terms. But essentially, paroxysmal that usually spontaneously terminates within 7 days. The persistent that goes beyond 7 days, and but it terminates spontaneously or by electrical cardioversion. The permanent one that doesn't terminate even on cardioversion attempts. So essentially, we understand that this Mr. GR, who has been experiencing palpitation since about 2 weeks, so technically it fits into a persistent AF. And next, we try to see is if there are any causes of AF. So as we know, there are big list of cardiovascular and non-cardiovascular causes of AF. And this Mr. Our patient, what he had was his advancing age, the COPD component, and the hypertension were few of the risk factors along with occasional alcohol that he would consume. Third, we try to see what will be a better thing for him, whether it will be a rate control or the rhythm control that will be better for him. And here we know the factors that favor rate control are if there is a persistent AF or there is a less symptomatic patient hardly has any symptoms. If the age is elderly age, if there is a associated hypertension, no heart failure, or the previous failure of antiarrhythmic drugs, and even at times patient's preference, then in that case, rate control strategy should be preferred. A rhythm control strategy can be opted for in case of paroxysmal AF or newly detected AF when patients are very symptomatic or a very young gentleman or lady and no significant hypertension or patient clearly develops heart failure when there is a AF or no previous antiarrhythmic drugs and even again patient preference. So in our case, as we see rhythm control, few favoring points were it was newly detected, he is young relatively, and there is no use of any antiarrhythmic drugs in the past or its failure. And what was favoring the rate control was he was not really much symptomatic. He is a hypertensive, no history of any heart failure. And there is a persistent AF and echo had shown mildly borderline, mildly dilated LA. So there were more factors favoring rate control rather than rhythm control. So the rate control strategy, as we know, if there are no cardiovascular disease, then beta blocker or diltiazem or verapamil, the calcium channel blockers that we usually use. In case of hypertension or heart failure with preserved ejection fraction, then again the same. In case of COPD, we really use beta blocker with caution. This rhythm control strategy, we no longer this is seen because Donaderon is out. Essentially, the drugs are the flecainide, propafenone, sotalol. These are not very commonly available at all the counters, but yes, amiodarone is a commonly used drug. So practically for most of the physicians and all the doctors, essentially when it's rhythm control, people do opt for amiodarone. So in our case, let's discuss one drug like beta blockers. So like there was no significant history of any MI or heart failure or left ventricular dysfunction. Secondly, there was a COPD history, so beta blocker may not be the preferred choice. Also, there was a telmisartan that was going on. So there is some hypotension that is there. In case of calcium channel blockers, that is verapamil and diltiazem, when we know that is COPD, and then these drugs don't have any risk of bronchoconstriction, so could be preferred. Suppose if we go for this drug, then compared to two, if that's elderly, then diltiazem, as we know, has got is better tolerated as verapamil has got some incidence of constipation associated. And blood pressure only needs to be closely monitored. Digoxin, not really a preferred drug these days because of not great efficacy when the patient is mobile and exercising and all. It can be used as an add-on therapy later if the rate is not controlled. And the efficacy-wise, it's not as effective as a beta blocker and calcium channel blocker. So basically, we decided to put him on diltiazem, that is a long-acting. Along with that, anticoagulant, as we know, will be needed in this case. We do with the help of CHA2DS score and the Hazlitt score and all that. And so we started on that. And plus, I prefer calling these patients after 1 to 2 weeks to see if the efficacy is there. That is, if we are trying to control the heart rate, the baseline heart rate, we say a strict control when we want to keep it below 80 or liberal control when we want to keep it below 110. So usually I see if it is less than 100 and patients are okay, around 80, 90 kind. And we see for the safety if there is any bradycardia, anorexia, nausea, anything, any edema. And if because patient was on blood pressure medicine, then even these are borderline causing low BP, if the BP is borderline. So we have to watch for hypotension. Essentially, these were the approach that I wanted to discuss. And yeah.
Oh, sorry, I was unmuted, is it? Yeah, can you hear me now? Yeah. Yeah, okay. So, Am I audible?
Yes, sir, you're audible.
That's the usual run-of-the-mill patient that you would find. He has had just 2 weeks of palpitations. And then he, very importantly, Dr. Sunil pointed out all the various factors that you will take into account before deciding about his rhythm itself, whether you continue to let him be in AF or should you try to convert him into sinus rhythm. Okay, so he's obviously hemodynamically very stable, has got 2 weeks, not just 7 days of recent onset palpitation. So in that sense, the old classification really helps. So it was indeed interesting for our audience to know definitely as to how to go about a patient with AF that you first time encounter with, right? So that is one aspect. So as far as this particular case management is concerned, I will like to bring in Dr. Gaurav Verma. Would you have managed this any differently, or would you like to add something that you would like to know about the patient, Dr. Verma?
Good evening, sir.
Go ahead.
Yes, Sunil has clearly presented all the protocols and what are the things what we usually follow when we have a atrial fibrillation patient. Important thing is we should also understand what is persistent and what is a permanent effect. If the patient does not have any sinus rhythm period in between, that means the patient is having a permanent. So if the thing is permanent phase, then we may not consider for a rhythm control. Then rate control comes into picture. If we have some documentation of previous ECG of sinus rhythm, then probably we can think of controlling it to a rhythm disturbance. We can control to sinus by DC version or chemical cardioversion. So one thing. Other thing, as per the protocol of today's program, we should be sticking to our theme of anticoagulation. For that, coming to that, like he rightly gave rivaroxaban 20 milligram. So the question arises that of the all NOACs, we are now have off patent apixaban as well. Before that, earlier first of all Dabigatran and Dabigatran came off patent, then came rivaroxaban. So sir, my question to forum is that why rivaroxaban, why not apixaban, why not Dabigatran? This is always confusion because till now we don't have a head-to-head comparison of all the three drugs. We do have meta-analysis which do show supremacy of apixaban in terms of bleeding prevention. But as per your knowledge, what will you prefer, rivaroxaban for a OD dosage benefit or
see this
purpose? Because he is 56-year-old, there's always some chance.
Yeah, he's a young man today. Now, what is very important is that this gentleman is young, all right. His CHADS2 score, we would have calculated, is definitely more than 2, is 2 or so, right? So, having said that, of the three, which one to choose happens when we have specific scenarios involved. Like this particular patient did not have anything except for the fact that as far as Hasbled score goes, alcohol comes into picture, and he is very rightly advised him to stay off alcohol. One very important pointer out here is the creatinine clearance or just creatinine of these patients. So whenever you start either of the three DOACs, a patient on any of the three DOACs that are currently available to us, I would insist on knowing as the monitoring, we always try and think that no INR monitoring, but in a hot humid place like India and especially Mumbai, like that place, okay, and all over the country, the humidity and also the heat factor being there. So our patients, even the elderly patients, when they tend to get dehydrated, the creatinine clearance changes from time to time. It's very dynamic. And creatinine clearance monitoring is absolutely essential for all the NOACs because they're all renally eliminated. Yes, amongst if say for instance, this patient had a high eGFR, okay, he was like he was in the 30 to 60 range also, I would still go in for either rivaroxaban or apixaban because dabigatran is 80% renally eliminated, okay. So strictly any kidney dysfunction issues come up in the very elderly, I would stay away from dabigatran. So why rivaroxaban? Now again, just to talk for dabigatran, if at all, versus the other two agents, what do you have to say, Dr. Puneet, Dr. Sunil, about the need for an antidote here? Does that availability of antidote matter in practice, or what is your take on that? Dr. Sunil, would you want to elaborate on that?
Yeah. I have kept my approach very simple, sir, for choosing NOAC. Patient I know compliance issue, of course, the creatine and things are, as you rightly pointed out, RFT, LFT part we have to see. But if the patient I know compliance is going to be issue, then I prefer rivaroxaban over the others because of the OD thing. If the thrombotic risk is very high, then dabigatran 150 would be my first thing. If the bleeding risk is high, then of course apixaban will be the preferred choice for me. That's as simple I can keep. Honestly, sir, I would like to know from others also how much actually we come across really some major bleed, and how many of us have actually asked for an antidote, sir. Up till now, I'm yet to use even once, to be honest. The max and availability, sir. Even if I want to use, it's not the available thing at everywhere. You actually have to call up for it, and that may take nothing less than 2 hours. Here in Mumbai, only pizza can reach in half an hour, sir, nothing else. So,
Yeah, that you very brightly pointed out, because I wanted to, for the benefit of audience, purposely bring in this antidote concept or otherwise. See, the fear of bleeding is something that has kept away not only, I'm talking about general practitioners and internists, but even I've seen some cardiologists who stay away from even anticoagulating atrial fibrillation. A very important pointer here is that fear of bleeding is something that you should not be worried about. And actually, your error of omission also should be, if it were medical legally, if you are liable, you should be made liable. Once you see a patient of atrial fibrillation, think of him as somebody who is got a potential to get a brain stroke. So when you see atrial fibrillation on the ECG, I generally like to, in my presentation, also show a picture. There are those nice illustrations wherein they show AF and straight the brain stroke. So that prevention should keep us away. So that fear of bleeding, confidence factor wise, with dabigatran, you have it on board. That is about all. But very rightly said, clinically it does not matter at all. I have yet to use this thing as an antidote, Pradaxa. Again, when you use Pradaxa, do you get the antidote? We don't want to bring in the brand names, but that's what I'm trying to tell you. But non-availability of antidote should not deter us from prescribing DOACs and DOACs over warfarin, given their predictability of anticoagulation. Now, coming back to bleeding as an issue, I definitely consider apixaban preferred molecule as compared to the other two as far as bleeding goes, especially GI bleeding. With GI bleeding, I would really want to stay away from rivaroxaban, because in the trial, though there are no head-to-head comparison trials, I would stay away from rivaroxaban. Again, unfortunately for us, rivaroxaban is available in various doses. So, and homeopathy is the norm when it comes to practice in India. We somehow start believing that Indians require low doses. Even for heart failure, we would use Ramipril 1.25 because it's by and large available here in India more often than in the Western world. And we are used to saving on cost by breaking tablets. So rivaroxaban, given the various dose schemes that it has, one must remember that 20 milligram OD is the dose for people with a good creatinine clearance. But again, if the creatinine clearance, as was in the trial also, I believe that if the creatinine clearance is less than 30, then you want to go for 15 milligram OD. As with apixaban, again, if you were to use apixaban, you just don't go by creatinine value. You also take into account the body weight of the patient. Less than 60 kilogram is the one when you go for a low dose. Then again, you take the age less than 80. So for instance, if you have as also creatinine more than 1.5, all these three things mean that you use a 2.5 dose. Again, for benefit of all the audience, I might like to tell you that rivaroxaban is available as a 2.5 milligram strength also. So don't do homeopathy when it comes to atrial fibrillation. It's for patients in sinus rhythm and chronic coronary artery disease, where on top of aspirin as a secondary prevention, you can use in addition rivaroxaban 2.5 milligram BID. So besides that, I don't think we need to add much to what Sunil, excellent presentation. Again, what I liked about in your presentation, though you used an old time chart, a table, you in your own slides, you mentioned the fact about LA size. Mild LA dilatation also means, and that's what the electrophysiologist Yash Lokhandwala must have always been talking about. Let's look at the LA size when you talk about all this, right? So then you prefer rate control again when the LA size is more, and otherwise you might. I will tell you about an interesting patient that I had, reversible and irreversible factors. We had an atrial fibrillation in a patient who had failed, actually. They had put it as recurrence of pulmonary valvular stenosis, a young adult. He was like in his 25-year of age, and it was all the atrial fibrillation was coming from the right side, of course. And then I balloon dilated him with an Inouye balloon because they had failed to dilate because the balloon ping pong. So after pulmonary valve dilatation, his reversible factor is taken care of. He was on anticoagulation for atrial fibrillation, and then soon I got him off the anticoagulation, kept him in sinus with Cordron, and then later on, about 6 to or a year down the line, the patient continued to remain in sinus. I got him off Cordron and also got him off all anticoagulation. So there are certain reversible factors. Now this was a right heart RA dilatation, but we got him off the Cordron as well as off the, because of reversal of remodeling in him, as well as the anticoagulation. So otherwise, once in AFib, you are destined to have anticoagulation all your life. Maybe we could, Aniruddha Vyas is on board as an electrophysiologist. Would you want to add something, Aniruddha? I can see Dr. Ankit also. Both of you could add something, and then we could move on to the next case.
One question has been asked, sir. One question has come. So that in chat, what is the duration of Revive NVAF and when we can stop? Score was.
Yeah, and you have answered it. And I was just mentioning that this is a lifelong anticoagulation unless you have a reversible factor. Like I just mentioned to you about a case where the RA dilatation had come down, everything had come down. He was in sinus rhythm over a year, and then I had the courage to get him off the antiarrhythmics as well as further later on off also the anticoagulation, and he's on a follow-up now 3 years later. He's doing very well and is in sinus rhythm. So Dr. Ankit, would you want to add something? Otherwise we'll go ahead with your presentation next.
No, so good evening, sir. Hi, Sunil. So basically, wonderful presentation by my friend Sunil, and just what you said was perfectly right, that we don't use Praxbind that frequently. So the antidote effect of Pradaxa or Dabigatran is not what we see in routine day-to-day practice. I have used Praxbind in one of the patients, but it was, of course, it was a neurological, it was admitted under a neurologist. I was referred and we used it. Patient is doing well now, but this patient was having atrial fibrillation. He had a previous ischemic stroke and was put on Dabigatran. He was on Pradaxa and got the Praxbind dose at the right time. And now the patient is ambulatory. Of course, there is some partial weakness in the upper limb. Lower limb, he's moving well. But what you said, I totally agree that this is in last 15 or 18 years of my cardiology and 20 years of my medicine practice is the first and only patient that I have come across practicing in almost 12, 15 hospitals in Bombay. So it's very rare. And the advantage of the antidote is extremely, I would say that this patient was very lucky to get the drug on time. And he was also important that this patient was enrolled in the antidote protocol of the drug company. So I don't think that this protocol is present for all generic Dabigatrans. So again, that is also a big issue, whether Praxbind would be beneficial to patients on generic Dabigatran. We don't know. And
There
Yeah,
are
and
two
it comes
case reports. There are two case reports reported from India about Praxbind, and one both from Mumbai actually. So that is what it is. The interesting aspect of it is that you can reverse with Praxbind, and even you can, if he is in the window period, you can use thrombolysis as a means of dealing with the acute ischemic stroke. So that's one thing. And taking it forward, that point in time, I was in a discussion with the others, and you can utilize it to even do a primary PCI for that matter on somebody who is on a
correct.
Pradaxa. Yeah. So let's move on with your case, Dr. Ankit. That's very excellent. Excellent presentation, Dr. Sunil, and that was a very good discussion. Let's go ahead with Dr. Ankit's presentation next.
So I'll share from my side. Sunil has taken care of the atrial fibrillation part, and I'm going to discuss about the homeopathy dose, as sir rightly said. Of Is my slide visible?
Yes, sir.
Yeah,
Yes,
it's
sir.
Hello.
visible and
Yes,
you're
sir.
audible. Go ahead.
So I'm going to present on the 2.5 milligrams rivaroxaban dose. So I'm going to start with a case of CAD with PAD. So this gentleman was 61-year-old, came with chest discomfort or exertion with of CCS class 2, claudication history from 1 year. Patient is already a diabetic hypertensive, long-standing, had an ischemic heart disease. 12 years back, he was plastered for LAD, followed by a CABG 2 years later. Uh, After that, that is 3 years back, almost 7 years post CABG, has undergone an RCA plasty and diffuse atheromatous disease in both lower limbs. On investigations, ECG showed sinus rhythm with LVH changes, mild LV dysfunction with regional abnormalities of the inferior wall. EF was around 45. Doppler studies of both lower limbs, arterial Doppler showed diffuse disease of the anterior tibial and the posterior tibial, more on the right side. Coronary angiography showed patent Lima to LAD graft and a patent SBG to PDA graft. LAD and RCA totally occluded, with circumflex showing mild coronary artery disease. Diagnosis was, yes, of course, coronary artery disease with triple vessel disease with patent grafts, SVG to PDA and Lima to LAD. Peripheral artery shows diffuse disease. No intervention was possible because we had taken two opinions as well from the peripheral artery specialists. Now, the patient was on treatment with aspirin 75 milligram once daily. Patient was put on rivaroxaban 2.5 milligrams BID, rosuvastatin 20 HS, metoprolol 50 once daily, ramipril 2.5 once daily, ranolazine 500 twice daily, sitagliptin and metformin once daily for diabetes control. Now, coming to with this case behind our back, patients with coronary artery disease remain at very high risk for ischemic events, and this risk increases if the patient has only risk factors. Then the risk is almost 9.1%, but it increases significantly when you add risk factor along with stable atherosclerotic disease. It increases further if there was a ischemic event in more than 1 year, and if the prior ischemic event was less than 1 year, then the risk of having a cardiovascular death, MI, or stroke at 4 years is almost staggering 21.1%. This was shown in the REACH registry, which had 4-year outcome data of almost 65,000 patients more than 45 years old. So this was a mammoth number of data that we saw, that when the risk factors are there, the risk is lesser. But when the events increase, if there is atherosclerotic disease increases or ischemic events occur more frequently. So in these patients, what is our main basis of treatment coronary artery disease patients? The vascular protection therapeutic pillars that we say. First, most important is lifestyle modification, having a healthy diet, physical activity and exercise, cessation of smoking, weight control, psychosocial support. All that comes as a lifestyle modification. Then the 4 drug pillars that we have, that is lipid lowering, statins, ezetimibe, PCSK9 inhibitors, that is Repatha, and the recently added bempedoic acid. Secondly, blood pressure control with ACE inhibitors, ARBs, beta blockers, CCBs, diuretics. Thirdly, well-managed sugars, that is insulin, metformin, sulfonylureas, DPP-4, of course, SGLT2 inhibitors, GLP-1 agonists. There are a lot of options now. And most important and most likely used antiplatelet or antithrombotic regimens based on single dose aspirin or single dose clopidogrel or double antiplatelet therapy. Now, is there a scope for improvement with current antithrombotic regimens? So, what are the NOACs that we see in India? If you see across the coagulation pathway, there are 3 drugs that are available in India. One is factor 10A, 2 are factor 10A inhibitors, that is rivaroxaban and apixaban, and one is a DTI, that is dabigatran. Today we are going to discuss about rivaroxaban. So, antithrombotic therapy strategy in patients with CAD. Now, this is a very busy slide, but I would like to go through it once to just make it a point that why anticoagulation therapy is important in patients with coronary artery disease. So, patient who's having a stable coronary artery disease and is on single monotherapy of aspirin, history of multivessel coronary artery disease or MI between 1 to 20 years. If the patient has a yes, then you have to look for additional risk factors like diabetes, peripheral artery disease, CKD, heart failure, or prior non-lacunar ischemic stroke. If the patient has a yes for that, then it's an indication for oral anticoagulation. Of course, you have to look for any high risk feature in this patient for life-threatening bleeding, anemia, history of spontaneous major bleed, bleeding diathesis, thrombocytopenia, liver disease, intracranial vascular abnormality, neoplasm, extreme old age, and frailty. If this is not there, then aspirin should be added with rivaroxaban 2.5 mg BID. And coming to the second arm, the patient comes with an MI and treated with a DAPT. You do an angiography, patient undergoes a bypass versus a PCI versus a conservative therapy. After the treatment with a PCI or a bypass, 12 months of DAPT, following 12 months of DAPT from a bypass patient, again, this patient should be reassessed and look for causes for any additional risk factors like diabetes, peripheral artery disease, CKD, heart failure, and prior non-lacunar infarct. Then if again this patient falls into the category, if it has any risk factors involved, then there is an obvious indication for oral anticoagulation therapy with a rivaroxaban 2.5 mg BID. And when you're considering PCI, conservative therapy, in such situation also, or a patient who's not tolerating ticagrelol, then also in this situation, these patients fall automatically in the category where rivaroxaban 2.5 mg BID should be added. So why this guideline? Why have I shown this data? This data is based on this landmark guideline in 2019 that was published. The recommendation of 2019 shows clearly adding a second antithrombotic drug to aspirin for long-term secondary prevention should be considered in patients with a high risk of ischemic events and without high bleeding risk. There is an obvious class 2A with a level of evidence of capital A. And this is for high risk. And for moderate risk, it is class 2B. Now, how do you define high risk and low risk? High risk patients are high ischemic risk is patients with diffuse multivessel coronary artery disease diagnosed with at least one of the following, that is diabetes requiring treatment, recurrent MI, peripheral artery disease, CKD with an EGFR between 15 and 60 ml per minute. So these patients are considered as high risk patients, high ischemic risk patients. And when you are considering moderate ischemic risk, these patients should have at least one of the following, that is multivessel coronary artery, diffuse coronary artery disease, diabetes, recurrent MI, PAD, heart failure, and CKD with a EGFR of between 15 to 60 ml per minute. So that's why aspirin plus rivaroxaban, that is considered as a dual pathway inhibition, targets both platelet activation and persistent thrombin generation in chronic CAD. So if we divide this thrombotic events into two phases or the time period between two phases, one is acute phase where prevention strategies are DAPT for 1 year, where you are considering platelet activation is stronger in acute phase. That's why we offer, or we obviously opt for a DAPT, that is dual antiplatelet therapy. And in the chronic phase, when you are seeing that the thrombotic events are occurring or ischemic events are occurring more so because of prolonged thrombin generation, in such situations, DPI, that is dual pathway inhibition of aspirin plus an anticoagulant like a low dose rivaroxaban 2.5 mg BID fared much better. Again, coming to a landmark slide or a landmark trial, I would say, among the all anti-thrombotic secondary prevention trials that we have, the CAPRI, Charisma, Pegasus 1, 2, Pegasus 1 involving ticagrelor plus aspirin, Pegasus 2 involving ticagrelor 60 plus aspirin, none of these trials had any obvious mortality benefit. Now, coming to COMPASS trial, rivaroxaban 2.5 milligrams plus aspirin had an obvious MACE reduction of 24%, had a significant, which was significant, had a significant cardiovascular death reduction of 22%, a mammoth reduction in stroke of 42%, which was again clinically significant, statistically significant, and a reduction in MI, which was not very significant. So this, among all the trials that we had, COMPASS is the only anti-thrombotic regimen showing significant reduction in all-cause mortality among all the drug trials we have. So, discussing about COMPASS trial, what was the patient profile that was considered CAD versus PAD? Inclusion criteria for CAD patient was previous MI within last 20 years or multivessel coronary disease with symptoms or history of stable or unstable angina or multivessel PCI or multivessel CABG surgery. Patients with CAD must meet at least one of the following, that is age more than 65. If age less than 65 plus atherosclerosis in more than 2 vascular beds or 2 additional risk factors like current smoking, diabetes, lesser EGFR of less than 60, heart failure, or non-lacunar ischemic strokes for more than 1 month earlier. So this was coronary artery disease arm. And if you see peripheral artery disease patients, previous revascularization history, previous limb or foot amputation for arterial vascular disease, history of intermittent claudication, and one or more of the following, that is ankle arm BP ratio of less than 0.90, or a significant peripheral artery stenosis of more than 50%, and a CAD plus low ankle brachial index of less than 0.90. So, of course, these are very elaborate inclusion criteria, but I wanted to discuss this. I just wanted to brief everyone what to say. So, COMPASS trial, again, just going through the slide, 27,000 plus, we all know the trial, 27,000 plus patients with stable CAD or PAD was having 3 arms. One was aspirin 100 milligrams or daily, rivaroxaban 5 milligrams BID, and rivaroxaban 2.5 milligrams plus aspirin 100 milligram daily. A median follow-up of 29 months, almost 1.9 years, randomized double-blind trial. COMPASS is the first NOAC and antiplatelet combination therapy trial to demonstrate significant reduction in MACE in stable atherosclerotic disease patients. So you can clearly see the cumulative hazard across time was much lesser with rivaroxaban 2.5 milligram BID plus aspirin as compared to rivaroxaban 5 milligrams alone or aspirin alone. So MACE rate reduction was 24%, net benefit was 20%, and mortality reduction was 18%. So no benefit was seen for rivaroxaban alone. So again, primary outcome, 24% lower with 2.5 milligrams rivaroxaban plus aspirin, more than aspirin alone. So again, that was important to understand. So switching from dual antiplatelet therapy to dual pathway therapy in the right patient is important as per the COMPASS data that we have. Therapeutic use and clinical benefits of dual pathway therapy in both CAD and PAD patients have been seen thoroughly. And as per the NICE guidelines of 2019, rivaroxaban plus aspirin is recommended as an option for preventing atherothrombotic events in adults with CAD or a symptomatic PAD who are at high risk for ischemic events. thank you. With that, I would like to end my talk, and if Praful sir can just.
Yeah, so the paper is now open, and there are, as expected, for this so-called homeopathic dose. No, it is not. It's quite a powerful dose that one must remember that it's a 2.5 milligram BID dose that you give. It's overall 1/4 the total dose that you would give for stroke prevention in atrial fibrillation. So, of course, here the fear of bleeding may not be there is what you might be thinking, but no. Unlike when we use it for stroke prevention in atrial fibrillation, where it is a class 1 indication, and irrespective of the Hasbled score being high, you just want the Hasbled score to understand the bleeding risk is only so that you take cautions and precautions to see how you would prevent bleeding in them. Like the patient of Dr. Sunil, he very clearly told him that he has to stay off alcohol when he started on rivaroxaban, but yet you cannot go away from anti-thrombotic therapy. But in a chronic coronary artery disease scenario, as Dr. Ankit so very clearly pointed out, that herein you have to first rule out a high bleeding risk. See, Dr. Jatin Kothari there has been asking me that the usage is low. The fear of bleeding is something that keeps everybody, deters everybody from starting. Now, herein for chronic coronary artery disease patients, which means you are past 1 year of having had either your acute event or have had your stenting or a CABG, and for secondary prevention, you are going to be giving an add-on therapy to aspirin, and you are definitely concerned about bleeding. And therefore, before giving this COMPASS dose, the vascular dose 2.5 BID, you have to have a mental chart, or you use whatever score that you want to use. There's a good BARC score also with a good illustration which might be stuck on your OPD practice also, and just a mental rule out that he does not fall into high bleeding risk. Then you are good to start rivaroxaban 2.5 BID for a patient. Now, going by the COMPASS enrichment criteria, okay, the COMPASS enrichment criteria, again, very clearly Dr. Ankit pointed out to us, you want to look at more enrichment criteria. For instance, if there is somebody young who has had out of the blue an MI, has a multivessel disease, does not have polyvascular disease, which means associated PAD as what Dr. Ankit's patient had, okay, or associated carotid artery disease, symptomatic carotid artery disease, or symptomatic PAD, or carotid artery disease, even if asymptomatic, more than 50% stenosis in the carotids, that you have polyvascular, which means more than one muscular bed. That's your first enrichment criteria that was there in the trial also, okay. Then, of course, after having ruled out high-risk bleeding, then patient of congestive heart failure, LV dysfunction, but not in acute decompensated heart failure. That's what the Commander HF trial was about, where it was negative. You want chronic LV dysfunction patients, then that becomes the second enrichment criteria. Then paradoxically, CKD, where I am talking about, be careful about creatinine clearance in this patient. But if you have a moderate CKD in this patient, then that becomes another enrichment criteria, because these are at high risk of strokes as well, high risk of MI CKD patients. And finally, diabetes. So all this 4 enrichment criteria, if you have, then I, for one, in my practice, Dr. Jatin Kothari has asked that I would go and use, because as a purist, the trial was about aspirin and rivaroxaban. Therefore, I would go with aspirin and rivaroxaban. But more and more data that we are getting about aspirin being the villain in the showpiece, in the sense that bleeding is more with aspirin. Somebody is asked, why wouldn't you empirically combine with clopidogrel? You may do it, but that is empiricism, not shown by any trial as such. Although clopidogrel has been used with vascular dose, for that matter, even ticagrelor has been used with vascular rivaroxaban dose in the Gemini ACS trial. Okay, of course, it was not a trial on the basis of which we would use in acute coronary syndromes. But yes, it might make sense to go with clopidogrel along with this if you are comfortable, but you would not have a trial data supporting that as of now. So having said that, let me bring in all our experts for the day. on board. Let me first call upon Dr. Gaurav Verma. Gaurav, do you want to add anything more to what we've discussed in terms of, this is very important. Even a lot of doctors have pointed out here, Dr. Raghavendra has also pointed out, and others have also pointed out that surprisingly, the usage of 2.5 BID dose in addition is low. Because what we all believe is that if we cause bleeding, the doctor has given it. But if a chronic coronary artery disease patient gets a stroke later on in life or gets a recurrent event, the God is to be blamed for that, right? But that is an error of omission, and we should be seriously considering this in patients who are at high ischemic risk. Definitely so. Yes, Dr. Gaurav.
I just went away. There was some emergency. So exactly, I just wanted to say same thing that for this kind of subset, whatever you said, we have to follow the same protocols, and guideline-based approach should be the key. Whatever the guideline says. And at the moment, we don't have data for the antiplatelets, isn't it, sir?
Yes, absolutely. There is a very important question that I think Dr. Ramesh Kandva pointed out, or something related to bleeding risk with this kind of, see, now you're combining two pathways, the antiplatelet pathway as well as the anticoagulant pathway, therefore acting on two different mechanisms, which was even done with good old warfarin in the past, but the bleeding was prohibitively high, especially intracranial hemorrhage. So therefore this very ingeniously designed dose of 2.5 BID with rivaroxaban. So the bleeding, what if bleeding do you see bleeding after 1 year or through the lifetime you would see bleeding? If you were to look at the COMPASS trial itself, whatever bleeding occurred on this dual pathway inhibition occurred in the first few years. First year was the highest, and then it started going down. So bleeding as projected would go down, whatever bleeding you would have within the first 6 months to 1 year, and then you are good to definitely keep it on for, again, lifelong, as I would say. Yeah. Dr. Anirudh, do you want to add to anything here in terms of vascular dose of rivaroxaban that Dr. Ankit Dedia has pointed out so clearly to us?
No, sir. I think I agree with all your suggestions.
Yeah. So one more question is there. Yeah, that is the clopidogrel plus aspirin question from Dr. Rahul Shabari. Then there is, we already talked about 1 year. Post the 1 year, the bleeding risk definitely comes down and it plateaus out. So the net clinical benefit in the COMPASS trial was huge when you prolonged it. Unfortunately, the trial was prematurely halted because the endpoint was reached and it was safe. DSMB halted the trial at 23 months. Okay, it was designed to go on for 4 years, really. So we must not worry about bleeding in the long term. Yeah. Initially, of course, you will take all the precautions to try and see. In fact, all this kind of dual pathway inhibition dosaging that we do will land up unmasking colonic cancers as well. I've had one patient in whom there was this bleeding that came up, and lo and behold, there was a cause for that bleeding. Don't blame it on the therapy. The cause for the bleeding was the patient had an underlying malignancy there. These elderly patients are likely to get underlying malignancy, and you must once in a while get their CBCs done, get their occult blood for stools done. That is what I would recommend, Yeah. But we must proactively give our patients preventive therapy. This is just preventive therapy. I at the outset tell all these patients, I'm going to add to your pocket budget, meaning in terms of adding a tablet, and you're not going to start feeling better in terms of your other symptoms that they have. It's just that you're going to not die of a stroke. That's important. Most importantly, stroke prevention.
Kirke sir, there was one, a funny question that in all the trials what we are doing with NOACs, whether it's in acute syndrome or in chronic or PVD, whatever, we are substituting aspirin for P2Y12, right? So why COMPASS was done with the aspirin? So this is a question everybody has asked.
Oh, very, very good question that is, because all this knowledge evolved later. If you go to see, the standard trial, the best trial there is the Augustus trial, okay, which was the first, which really showed that the aspirin was where you were using TAT, the triple antithrombotic therapy, dual antiplatelet for the ACS event or for the stenting that you have done, and because the patient has an indication for a NOAC, we can't get him off the NOAC. And so the NOAC also goes on. But that triple antithrombotic therapy today in the latest guidelines has been reduced to as low as
7 days.
7 days. Unless then you take, again, weighing the ischemic risk and the bleeding risk is important. Then you may change the therapies according to that. But those days it was not known that aspirin is the villain. But today I would agree with Dr. Jatin Kotari, was it, or Dr. Ramesh Kandwa, who said that, or Dr. Rahul, who said that you might want to combine with clopidogrel. For that matter, let me counter question Dr. Rahul, whether today you are comfortable on the basis of so many trials, and there was this Panther meta-analysis done at the ESC conference this year, where they took all the aspirin versus P2Y12 inhibitor trials, combined them all together. Of course, meta-analysis is the next best evidence compared to within a trial. We do not have within a trial a very hard evidence of aspirin versus clopidogrel, though we have in some host AMI trial last year at the ACC. So going by all this, intuitively, even I would say that I would even might want to switch all my patients, if affordability is not an issue, to clopidogrel once daily rather than aspirin once daily for chronic coronary artery disease patients. Today there is a lot of evidence, especially the meta-analysis evidence that was presented at the ESC this year by an European, I think Marco or somebody he was, who presented that evidence of Panther. Panther is the name of the study wherein they have taken into account all the aspirin versus P2Y12 inhibitor trials, and they've said that just giving a P2Y12 inhibitor would be efficacy wise in terms of preventing thromboembolic events great. Not only that, bleeding would also be lower, just with one P2Y12 inhibitor as against aspirin. So unfortunately, good old aspirin, aspirin, we moved from
maybe out of the our practice probably next few years. So
yeah.
Sir, what you said, if I sum up, like Augustus has shown that you can add just a P2Y12 with apixaban for whatever you do, plastic with AFib, or you can avoid aspirin, right? Similarly, there was a recent meta-analysis of Atlas TB 46 and 52 for rivaroxaban, which also showed that rivaroxaban 2.5 even for 5 VD, if you combine with, but that was with aspirin, you can avoid the third antiplatelet. So probably with time, probably we have to use only 2 agents, one antithrombotic and one antiplatelet, isn't it?
Yeah, absolutely. There is such a strong indication, like for the first 7 days at least, that the guidelines talk about, or where the ischemic risk is very high, I might extend it further. But whenever we use this, the monitoring of that patient, you can't just start a patient on something and then forget about him. He has to either with you or your referring physician continue to follow up. That's what is important. Yeah.
And other things, sir, even after 1 year, suppose the patient with atrial fibrillation post-plasty, simple, not a bifurcation or a multiple stent plasty, you can just omit the anticoagulant, antiplatelet. You can just continue the this antithrombotic like NOACs. You can just continue a single agent. You can even kick off the.
Yeah, but that single agent continuation is in an AFib scenario. Yes, not in a sinus rhythm patient of chronic thromboembolic of some kind. We
of course.
want to do it for that patient.
Right.
Yeah. So with that exciting, meaning that was a very healthy discussion. I'm sure the usage, as somebody mentioned, people are not using it as much. I am sure after our delegates who have attended this, they do not seem to have any more further questions. We'll move on to the next topic. Yes, this vascular dose, the so-called homeopathic dose, we must be using it more often, either with one single antiplatelet agent, preferably P2Y12 inhibitor, but there is no trial data for it. But otherwise, like the COMPASS trial with aspirin. Moving on to Dr. Aniruddha Vyas, who has been introduced to us as an electrophysiologist and who will now talk about an interesting case of pulmonary embolism, I guess, right? Let's go ahead.
Thank you, Praful sir. It is an honor to speak before you. I will share
Oh, yes. You started with a rhythm electrophysiologist. Yes.
So, are the slides visible?
Yes, very well visible. Just go on the
Yeah.
slide. You have
So,
audible and visible. Go ahead.
Praful
fair
sir,
enough, sir.
Anirudh has worked with us in Holy Family under Dr. and we had the privilege of working with him. So between me, Sunil, and Anirudh, we've got a lot of time spent together in the cath lab.
Oh, great. So, like you said, and now we have all the delegates also. So, it's a big family gathering. The delegates are also a part of our family. Go ahead, please. Yeah.
Yeah.
And
So, when we is this audible?
yeah, now you're audible. You cut off for a while. Yeah, now you're audible. Go ahead.
All right. So, so when we talk about atrial fibrillation drugs to manage them, rate control, rhythm control, anticoagulation, there are 2-3 important observations which I would like to stress upon. We all know that. So, using anticoagulation for atrial fibrillation does not depend on the duration of the AF, whether it is paroxysmal or chronic or permanent or persistent. It depends on the CHADWA score, and the type of anticoagulation we choose depends on whether the AF is valvular or non-valvular. The non-valvular AF does not exclude all rheumatic heart disease patients. So it is the rheumatic heart disease with significant mitral stenosis and a mechanical prosthetic valve, which is considered as valvular AF. Rest all patients can be put upon the novel oral anticoagulation. Why it is important is because vitamin K antagonists are considered to have a lot of drug interactions, and most of these patients are already on so many drugs. As we talked about rate control and rhythm control strategies in Dr. Sunil's talk, I was compelled to share this ECG. Now, this was a 69-year-old lady who was put on rate control strategy. We should all understand that there are a lot of rate controlling medicines, and digoxin being just one of them. I just want to put upon that digoxin has a lot of drug interactions, and we can consider using beta blockers and calcium channel blockers in place of digoxin, because the toxic effect of digoxin in presence of so many drugs, it starts even before the therapeutic effect. So these two ECGs, upper panel and lower panel, they are being taken at a interval of 1 week, and we can see the toxic effect of digoxin already popping in, despite the rate control effect of digoxin not coming in. So that was one point which I wanted to make, that we should consider using novel oral anticoagulation over and above vitamin K antagonists, because they are considered to have less drug interactions with other medications. Also, in patients who presents with AF and we want to control the rate, we should refrain from using amiodarone as a rate controlling agent. Amiodarone is a drug to manage rhythm and to maintain sinus rhythm in patients with atrial fibrillation. So we see a lot of rheumatic heart disease patients in persistent AF and still on amiodarone as a rate controlling strategy, which Dr. Yash has told multiple times. My mentor has told multiple times in multiple meetings that it is absolutely nonsensical to use amiodarone as a rate controlling agent in such a scenario. So this was the second point which I wanted to make. Thirdly, I also wanted to make a point that we all should understand, and we see very frequently that patients with atrial flutter, they are not put on guideline directed anticoagulation regime. However, it has been clearly proven that atrial fibrillation and atrial flutter, they both require similar anticoagulation regime. The indications, the contraindications, they should be same. This ECG is interesting for me personally, because this patient was a 24-year-old young gentleman who was basically diagnosed as atrial flutter in a periphery, and was started on some drugs and was referred for radiofrequency ablation. The patient came, we diagnosed it, and we attempted to treat him. And you can see the post-procedure ECG. So Atrial flutter, of course, it is clear that this is not atrial flutter. The top panel shows sinus tachycardia with clear evidence of right ventricular strain, development of S waves in lead 1 and AVL, and T inversions in V1 to V4, and the classical S1Q3 T3 pattern. So this was a pulmonary thromboembolism and a massive one. And the patient presented, almost had a cardiac arrest in the emergency room, was thrombolized, was managed, had been put on anticoagulation. So this was one thing. We started him on novel and oral anticoagulation. Then we should not just stop on finding out, we should not just stop by putting them on anticoagulation, especially in young patients with no risk factors for venous thromboembolism. While evaluation, we found that he had big inguinal lymph nodes. So possibly initially we thought because of the venous stasis, he developed deep vein thrombosis. So, but we started him on some antibiotics and followed him up after a week. The lymph node did not regress. And then later a lymph node biopsy was done and he was diagnosed as non-Hodgkin's lymphoma. So non-Hodgkin's lymphoma presenting as inguinal lymph nodes leading to deep venous thrombosis and presenting as pulmonary thromboembolism, misdiagnosed as atrial flutter. So this was the interesting case scenario which I came across. So he's under treatment now. So this is the second aspect I want to put forth. So pulmonary embolism. So this picture is from Professor Whelan's ECG textbook on emergency medicine, and acute pulmonary embolism can mimic a lot of cardiac conditions, cardiac emergencies on ECG. Principally, we can see the pre-embolic and post-embolic ECG, and we find sinus tachycardia, the rightward shift, S waves in 1 and AVL and Q and 3 AVF, and also T inversions in V1 to V4 and ST elevation in V1 and AVR. So largely ECG features which suggest right ventricular strain should not be missed upon on any patient who presents with acute or subacute onset breathlessness, chest pain, and desaturation. With keeping scarcity of time in mind, I would like to end it here.
A very interesting presentation indeed. The first set of ECG that's showing. You might want to go back to your first set, and herein
Yes,
you might want to really, for the benefit of the audience, show everything that is there. In the first ECG itself.
Yeah.
Not
Is it
this
visible?
one. I'm talking about the second one
Yeah.
of pulmonary embolism.
Yes.
So this is so classical, isn't it? That you have a RV strain, you have a right axis deviation in this ECG, you have T-wave inversions V1 to V3, you have a sinus tachycardia of more than 110, one of the high-risk features for SPACE, that score that we talk about, simplified PACE score, isn't it? We have a right axis, we have T-wave inversions V1 to V4, which is there. So acute RV strain is seen even in this ECG, which is otherwise just a sinus tachycardia, isn't it? And heart rate. Add to that, if you have a desaturation of less than 90, as also you have a blood pressure which is less than 90, then you have all the features to suggest that this is a very extremely high risk patient, high risk of mortality, and therefore once you have ruled out that there is no bleeding problem with him associated, you are good to give him thrombolysis as the fastest means of dealing with that. Post the thrombolysis, you might want to elaborate and tell us about how oral anticoagulants you would go about with in his case, and also the parenteral anticoagulation, Anirudh, for the benefit of and you see that the right axis has disappeared, though there is some memory sign of the V1 to V4. 1 week later, T-wave inversion still being there. The right axis has disappeared in this particular post-procedure ECG, so to say. Post-thrombolysis ECG 7 days later, that's right? Yeah. So would you want to please elaborate, Dr. Anirudh, for the benefit of our audience, how do you go about giving parenteral anticoagulation along with thrombolysis? This particular case, did you think about parenteral anticoagulation? If so, vis-a-vis the thrombolysis, whether you started right away going into thrombolysis or you waited for thrombolysis to be done with, and what kind of thrombolysis doses did you use? Did you use Elaxim, tenecteplase, or did you use streptokinase? Because in a university hospital scenario, even sometimes tenecteplase becomes expensive, and streptokinase is one area which is approved for even pulmonary thromboembolism, right?
Yes.
And there are no head-to-head comparisons between the two, but we do use a lot of streptokinase as well. So would you want to elaborate on the dosing of the parenteral anticoagulation and then the oral NOAC as how you would go about it? Yeah.
So for this particular patient, so I've used tenecteplase, alteplase, and streptokinase. Most often I have used streptokinase for treating patients with massive pulmonary thromboembolism. This particular patient was also was given a bolus of streptokinase and later on started on infusion, and we monitored his saturations and right ventricle on echo. Repeat CT pulmonary angiogram showing absolute clearing of the saddle thrombus which was sitting was done 48 hours after starting thrombolysis. After 48 hours, we started him on parenteral anticoagulation, which was the low molecular weight heparin twice daily dosing. We continued it for 3 days, and then at the third day, we started him on NOACs right away. We started him on rivaroxaban, and we continued that. During the time of lymph node biopsy, it was an issue because the surgeons were telling because of the risk of the bleeding. So, but because the lymph nodes were reasonably superficial, we tended to not stop the rivaroxaban during the lymph node biopsy, and we could manage hemostasis despite that.
Okay, so you chose to give parenteral anticoagulation as low molecular weight heparin, which is perfectly fine. You did it after 48 hours, which is perfectly fine. But there is a school of thought where people might want to, given that you're given thrombolysis, and in such a scenario, you might even want to use unfractionated heparin, not to forget that you can just on and off it types, So unfractionated heparin could go along with thrombolysis or after thrombolysis, as also the fact that low molecular weight heparin is also perfectly fine. Then if this were not a hemodynamically unstable patient, then there are trials also wherein both rivaroxaban as well as apixaban have been started, especially for VTE and submassive pulmonary embolism, maybe low risk pulmonary embolism, with directly oral therapy also, isn't it? So, that's something that we could point out to the benefit of the audience out here.
True.
And that NOAC. Now, how do you decide about the duration of therapy here? Meaning, you want to elaborate on the provocable or the non-provocable causes versus how long would you give it, and what is the recurrence rate likely to be with pulmonary embolism? Yeah, Anirudh? Yeah.
So, as we found the
there is, of course, there is cancer involved. There is obviously
So we did find the inguinal lymph nodes which are compressing upon the femoral venous system, which could have possibly provoked the venous thromboembolism. However, we cannot completely rule out the paraneoplastic aspect of the lymphoma, although it was a non-Hodgkin's lymphoma. So presently now it is 4 months since we diagnosed and treated him, and still he continues to be on oral anticoagulation. I'm honestly not sure when should we be stopping it. Yeah,
that is what it is. But say this was not, after all, a non-Hodgkin's lymphoma, and you were dealing with pulmonary embolism without the fact that there was a non-Hodgkin's lymphoma already there. So extended therapy wise, how long? That becomes an issue very often as to how long you want to extend after all, whatever oral anticoagulants we are going to give, there is always that risk of bleeding also.
True,
As
very true, sir,
also,
very true.
one must always look at pulmonary embolism as something that has got a very high recurrence rate, especially in the first 1 year. So then as you go over the years, the 1 year, the recurrence rate may be as high as 13% to 10 to 13%, right? And
Right.
as you go further, 5 years down the line, also there might be a 25% incidence of recurrence still there. So how would you decide on extended therapy or lifelong therapy wise? That would come into question also, whereas there are no definite answers there. But suppose he was a thrombophilic disorder for any reason, then you might
Yeah.
want to consider
To
lifelong.
continue it for a lifelong anticoagulation. Yes. So if you
Yes.
find a identifiable and a removable provocant, only then we might consider anticoagulation for a limited period, maybe 6 months to a year. Otherwise, if we don't find a provocant, we might have to consider it for lifelong.
Yes, that is what. So provocable and unprovocable is one thing that you ought to look for. Of course, we always, any of these agents that we give, anticoagulants maybe, whether warfarin or for that matter, the DOACs, we almost always need to take into account what bleeding risk category does he fall into. And those things are extremely important. So very exciting. That case was very nice, Ankit. And may I bring in Dr. Gaurav for further discussion? Do you want
Sir, I wanted to add two things. One, like there's always a query about using heparin with the thrombolysis, like you asked him. So what is our protocol is that if we want to thrombolize with tenecteplase or retiplase or LTplase, this tissue plasminogen activator, which is the standard. Still we have only three as per the guidelines. Either you can thrombolize with tissue plasminogen activator with urokinase or streptokinase. So if the massive pulmonary embolism we want to thrombolize, so we give a bolus of LMWH 0.6. Then we thrombolize, we wait for the thrombolysis to end, and then we start again with heparin infusion for 12 to 24 hours. This is our protocol. Other guidelines also suggest that you can give LMWH also. In some trials, LMWH has equal benefit with heparin. But always you have to be careful about the bleeding tendency. You have to see the renal function, how the patient's morbid status is there, how the frail patient is. Depending on that, only you decide about the type of thrombolytic as well the heparin therapy. Second, regarding the oral anticoagulation that Dr. Vyas has pointed, there are two things to notice. One is that in all the trials with rivaroxaban only we can start without with a background of heparin. But with dabigatran and apixaban, we should give parental heparin also when we start oral anticoagulation. Third is about the long-term therapy, like you said. Then the thing come into picture is about the provocable pulmonary embolism or non-provocable cause. If we don't find any cause, then definitely you have to extend it for a longer time. But definitely there's two studies, one with apixaban, other with Einstein extended, in which they have decreased the dose and the result was similar. Like when we start with like 50 milligram BID dose for rivaroxaban, we can decrease to 10 milligram. Similarly for apixaban, we can decrease to 2.5 BD also in extended arm. They have reported that. So these were the some points I wanted to highlight.
Yeah, actually for pulmonary embolism, if I'm not mistaken, the dose for apixaban becomes 5 milligram BID as an extended thing. And in the acute phase, there are trials of even
7.5.
apixaban. In the acute phase, you give 10 milligram BID. Just
Yes,
like
exactly.
rivaroxaban is given 15 milligram BID in the acute phase and then made 20 milligram OD. Am I right? Something
Yes,
like
sir,
that?
exactly. Absolutely.
And also this one also, you can start off with 10 milligram BID of apixaban. That's also there. Now that apixaban is also off patent, we might do us good to understand what is apixaban dosing wise also, isn't it? Yeah. So yeah, that's a very good pointers that you brought out. Yeah, I was just trying to say that unfractionated heparin is still, in terms of you're giving thrombolysis plus you want to give a low molecular weight heparin. Herein you have a CTPA on board and you have a very classical ECG where it depends upon your the acute syndrome with which the patient has come in. For you to diagnose pulmonary embolism, up until this, you go by the pre-diagnostic testing done, how long will it take for your diagnostic testing to be done itself? CTPA, for instance, in certain busy hospitals might in itself take 4 to 5 hours, and you might still have a hemodynamically stable on board, and your this clues of ECG or your clinical suspicion, if you obviously have some DVT or if you have had a previous history of DVT in this patient, you might want to start some anticoagulation on board for sure. And in such a scenario, I'm okay even with unfractionated heparin bolus given and then a drip started, up until diagnosis is made. But you are very right when you say that low molecular weight heparin depends upon your preference. You can just give a shot of low molecular weight heparin and you're fine, especially if creatinine clearance is fine, then you are good to give a low molecular weight heparin immediately also. That's what it is. But yes, that this NOACs today have meant that we can treat pulmonary embolism, the hemodynamically stable ones, the non-submersive ones, the low risk or the lower intermediate risk ones, also directly with oral anticoagulants and oral anticoagulant, especially the novel oral novel, or we can also call them as non-vitamin K oral anticoagulants like rivaroxaban and apixaban, rather than worry about giving parenteral anticoagulation, which is so convenient. Right. Also, there is a school of thought where the very low risk ones, nowadays CTPAs get done at a drop of a hat, and then you come up with some little thrombus sitting here and there and you want to treat them. And there is a school of thought where you can even, if they do not have any other high risk features, you can even treat them on an OPD basis with oral anticoagulants. That is what it is. So overall, I think we had an excellent session on this DOACs today. And thank you so much, all of you, meaning all the three speakers, I'm sure have done an excellent job and all very exciting cases. We learned a lot. Actually, if you ask me, I also learned a lot, especially it's fun whenever my colleague Yash Lekhandwala used to put up those ECGs to try and decode those ECGs quickly and this particular ECG, which is, we are ending with that and not showing the whole audience. You may shut that off and we can get the whole all the faculty on board. You can put off the share screen, and so that is a very, very, very interesting ECG. Right in the ECG itself, we don't really need a CTPA to diagnose this patient. If this patient is in hemodynamic embarrassment, even if you had not shown that CTPA, he is a candidate on a clinical suspicion itself. A bedside echo gets done faster with us. Yeah, we would definitely have echo features of acute right ventricular strain there, a forgotten ventricle, so to say. We hardly ever look at the right ventricle, just look at LV functions. It's a sinus tachycardia, S1Q3T3, acute RV strain. That's a good enough reason to, if he is in very bad hemodynamic embarrassment, even to give a bedside thrombolysis, I would say.
Yeah, exactly.
Yeah.
So we started him, his thrombolysis based on echo and this ECG.
Oh, is that right? That's great. That's exciting.
Yeah.
That's the beauty of clinical medicine. You don't really need. But CTPA, if you're going to take a long time going in for a CTPA to make a diagnosis, and up until that, you must get some anticoagulation on board, maybe some parenteral anticoagulation on board, as also you must be bold enough to give thrombolysis. Paradoxically, hypotension is not a problem here. Whatever be the blood pressure, your vasopressors are on board. You might even want to intubate a guy if he has been on a severe hypoxemia, and go ahead and thrombolize this guy. Be bold will be the message that I would like to give. Do not fear blood thinners and clot busters. Be bold and use them. And I'm sure today's session would mean that all our audience will be getting bolder and bolder about the use of this knowledge of thrombosis and thrombolytics and anticoagulants. You may want to add something, Ankit would want to add, or maybe Sunil might want to add something before we hand over to Ravi again. Yeah.
I think your message was very loud and clear. These antithrombotics, anticoagulants, these are there to be used with some amount of doses. If you have some good scientific knowledge and backing, We don't have to fear those occasional bleeds that are there. Risks are by not using it and landing that patient in stroke and then saying, "Ye Bhagwan ke karan hua." No, that's not the right thing. We all as learned doctors should give our best to our patients. Occasional bleeding, then we can say Bhagwan ke karan hua and all that. But yes, we must use it more and more based on the scientific data that we have. Thank you, sir, for emphasizing this very clearly to us.
Okay, over to you, Ravi.
Yeah, sir. And it was really excellent session. And, we can see the kind of response what our delegates are giving. They're asking many questions, even they have asked about 4 or 5 questions, but, we thought that I already discussed it. So it was good session, sir. Overall, specifically, this is a lot of learning. We can learn more things specifically on thrombosis part, right? And again, thanks to Kerkar, sir. I think today we have crossed almost 200 registration specifically we are doing it for West Zone. In 200 cardiologists have consistently watched, since 1 hour they are watching this program, and they are asking questions. They want to understand more, they want to learn more. So learning attitude is there for everyone and it grows, sir. And thanks to you as that you are giving a lot of insights, a lot of discussion has happened today where we have discussed pulmonary embolism by Dr. Sunil Jaitanya, sir. Fantastic, sir. And then again, Dr. Ankit Dedia, sir, again, where we called homeopathic dose as a Euroxaban vascular dose as good discussion. And also, one of the very good discussion by Anirudh, sir, by specifically for atrial fibrillation cases, what we has discussed. I think that was very new to hear, so every time some new cases will be there for this program. And also thanks to Gaurav Verma, sir. Sir was really busy and, he's taken his time and he has really joined our program. So
he has always been like that. He has always been a busy man.
Sir, I just wanted to say before Ravi concludes, sir is very modest. Huh? Sir said he learned, but actually he taught us many new things. That first important thing that you should not miss your clinical sense. Like sir, that while looking at the ECG, what sir wanted to stress that if you find such ECG, you thrombolize even in casualty. This is a message which I got from that last case. And that is super that you can't forget your clinical sense and clinical judgment. Second is about the pre-test probability what sir was, enforcing. That always, look for your senses. Whatever you feel like you do it, because if you do in time, you will save much more than when you do it later. So of course, sir, we always have learned and you have been teacher to almost all the cardiologists around. So there's nothing more I can add. Over to you, Ravi.
So really, so nice of you, Gaurav, sir. Thank you so much. Really a very learning sessions today, and it will be continued. So every month we will do it. So once again, thanks to Kerkar sir, Gaurav sir, Sunil Jaitanya sir, and Ankit Dedia sir, and Anu sir. With this, we will close this program today. So thanks to all the delegates for watching this program. Thank you so much.
Bye-bye.
Good night. Good night.
Good night, sir. Thank you so much.